So the genesis of this particular uh, talk was again when Habib was asking me that you would be talking about recent advances in the morning, and since there will be a lot of postgraduates in the audience, can we talk a little more basics about evaluation of the lacrimal system? The topic that he gave me, Javed in the Wonderland, I didn't know what to talk about that because it looked very unique topic to me. But then I felt that this topic would justify because I still wonder what is the right way of evaluating a lacrimal drainage system. We still don't know. I still don't know what is a good technique of doing a lacrimal syringing or lacrimal irrigation. I still don't know how best to interpret lacrimal imaging and what is the best situation in that. So there are a lot of things that we do not know. The amount of things that we do not know about lacrimal drainage system is enormous. So I thought whatever I have learned over the past few days, a little bit of them may not be exactly accurate. So I just put forward those things. I bring to you greetings from the Institute of Dacryology across the campuses of L.V. Prasad in India. This is what I have already discussed. This is one slide that you would find in all my lacrimal presentations. It's a tribute to all these gentlemen and many, many more unsung heroes who over the past 2,000 years have contributed to lacrimal sciences, and it's because of contributions of each one of them and many more that I'm able to stand here and speak. So I wish them peace in their graves. All the images here are taken from my atlas. So these are some of the cadaveric dissections that I have done just to show you how intricate the anatomy of the lacrimal drainage is with the lateral nasal cavity. This is the lacrimal sac and this is the nasolacrimal duct which is opening. I've removed the inferior turbinate and middle turbinates. So you would see how beautiful it's opening and how intricate and complex that anatomy is. This is just an example to show with turbinates and without turbinates. And this is a completely excised lacrimal drainage from punctum to the nasolacrimal duct. So whenever we start with a clinical evaluation, we are fast losing on those traditional teachings of a meticulous history that the surgeons of the previous centuries used to take. So a good meticulous history and a good listening to the patient can give you a lot of clues about lacrimal drainage system. It could be previous medical histories of using, say, anti-glaucoma medications or prolonged medications. It could be previous surgeries on the lids. It could be many other things. But as a clinical evaluation for lacrimal drainage system, you should always begin with the face. You should never go to the lacrimal drainage system as such. You should look for the face to see for any asymmetry, any lumps and bumps, because all these can contribute to our diagnosis. Any mid-face ptosis that Rick was talking about in the morning, because they can lead to lid malpositions and punctal malpositions. And obviously the skin quality around the medial canthus can give you a lot of clues about the chronicity of the problem. Just to give you an example of face here, just looking at the patient who has come with irritation, I know what is happening there. There's a straight stent prolapse there versus infant, a neonate who's coming with a large bluish swelling. We know the diagnosis straight on what we are dealing with. Lid malpositions, as I say, it's very important. For some strange reasons which are still not known, 10% of lid malpositions have associated lacrimal drainage issues. So it's very important that we need to assess, other than the cause of it, they can have a lacrimal drainage obstruction also. Lid examinations, like Rick was talking in the morning, it's very important to do snapback test to give you an idea of lid laxity. A pinch test or a lateral distraction test can give you a lot of clue about the medial canthal tendon laxity based on the grading that you see here. This is where the punctum is supposed to be. If you are able to get the punctum to the medial limbus, it means it's a grade 2 laxity. You should never be able to get a punctum beyond grade 1. And then once that happens, you have looked at the face, you have looked at what is happening around, then start looking grossly at the eye. It can give you a lot of clues. Like, for example, this patient, if you see, There's a lot of inflammation, there's a lot of conjunctival swelling, conjunctivocalysis kind of a situation, which is impinging right onto the punctum. If this gentleman complains of epiphora, I know this is a mechanical secondary acquired lacrimal drainage obstruction, or exaggerated caruncle, hypertrophied caruncle, which can be part of old age or many other disorders of the sebaceous glands over there, can give you an idea. Then go ahead and look at the punctum. Now when you look at the punctum, it's strange. What is a normal punctum? Do anybody has an answer? We don't know. What is a normal punctum? So when we do not know what is normal, then how would we say something as punctal stenosis? So it's as simple as that. We are so ignorant about such simple and basic things, right? So the textbook would tell you 0.3 millimeters. Well, how do I go and measure 0.3 millimeters in a routine examination? And if you look at the papers that I have published using FDOCT of the punctum, in the Indian population, I have found a normal Indian punctum to vary from 150 microns to 800 microns. That is the range of normalcy for Indian population. So you're getting my point. So that's something important. So once you look at that, the first question should be, is punctum present or not present? So if it is present, like you see in this case, this is a case of punctal agenesis. And once you know that the punctum is present, it's very important to assess the congruity of the punctum with the ocular surface or the globe. Here, if you see this guy who's coming, young guy with epiphora, if you actually look at that, what is happening there? This guy has a little anterior insertion of the medial canthal tendon, a condition which is commonly called as centurion, which is usually seen more in Europeans, but few of the Indians as well. You see that one? So this is a centurion syndrome. That's the cause of epiphora. And then you have different kinds of punctum. Then you see whether there is a peripunctal fibrosis or whether there is a membrane over the punctum. Like you can see, there's an internal membrane, a condition which is called as incomplete punctal canalization that can lead to that one. Then you go ahead and evaluate the systems of the canaliculi a little forward. Is there any discharge over there? Is there any swelling over the canalicular area? Because that can give you a lot of clues. Then you assess certain things like Schirmer's or tear breakup, because at the other spectrum, other end of the lacrimal drainage, which is lacrimal gland, can also contribute to epiphora. And once that happens, you can also evaluate using the fluorescent dye disappearance. Some people call it fluorescent dye retention, either way. And then you grade them bilaterally. And this is one indication where you know that the lacrimal drainage system is patent. And once that happens, then you go stepwise towards Ropla's examination. Ropla's is regurgitation of pressure over lacrimal sac area. That indirectly gives, it's not a foolproof, but indirectly gives for many patients an idea that this is probably a nasolacrimal duct obstruction that we are dealing with. And once that happens, you go ahead and say, for example, if Ropla's is negative, if FDDT is unequivocal, then you would go ahead and irrigate the patient. Now, the concept of lacrimal syringing is again not a good term to use. Syringing is what? Syringing is, even this is a syringing, right? So the preferred term is lacrimal irrigation. So once you irrigate, you dilate the punctum. Now, the question of punctal dilatation, the traditional teaching that first you lift it vertically and then you go laterally doesn't hold true, because the canaliculi is not how you feel it is in right compartments. Canaliculus has a phenomena which is called as the accordion phenomena. If you have seen the instrument, musical instrument accordion, the canaliculus is never that kind of a tube. It has a little wavy kind of a tube. So the better way of dealing with that is to lift and stretch it before you even enter the vertical canaliculus. The reason for that is that you'll protect the ampulla from the tip of your punctal dilator. And once that happens, any time you want to enter the canaliculus, for whatever reason it is, make sure whichever instrument you're using, this should lie on the lid margin parallel to it. It should be touching the lid margin, whichever direction it is. And that's where you get direct access into the lacrimal sac. So as I was talking about, you irrigate whichever way it is. I usually prefer the upper punctum rather than the lower one for irrigation because the upper punctum has a little more direct access into the sac, and you want an intra-sac irrigation rather than a canalicular irrigation. Now when you look at the cannulas that are used, very strange. These are, I'm just capturing these pictures from I specifically bought only for this one. You get a host of different cannulas, isn't it, for lacrimal irrigations? All of them are curved and all those things. But did somebody think, why are we using curved cannulas? Some person somewhere sitting by an error of judgment has made a curved cannula, and people are producing it left, right, and center, and we are using it. So if you look at any one of these, look at this one, so the height of it. So if you want to calculate the height of a cannula, you draw a straight line from here up there, and you take another line from here, and that gives you the height of it. And I have found that height to vary from 3 to 5 millimeters, the vertical height of a cannula once you are inserting into a canaliculus. Now what is the diameter of a canaliculus? The diameter of a canaliculus is 0.3, 0.4 millimeters, occasionally 0.5. So if you want to place a 3 millimeters through a 0.5, what would happen when you are going in and what would happen when you are coming out? You would be scraping the canalicular wall. If the canaliculus is a bit forgiving, it doesn't give us license to scrape the canaliculus, isn't it? So these are certain important things. So what is important to realize is that never use curved cannulas. Always use straight cannulas. You have 23 gauge, 25 gauge, 27 gauge straight cannulas. Depending on the age, you can use those things. So lacrimal irrigation, as I was saying, always have an intra-sac irrigation because you can mimic any kind of an obstruction. You give me a syringe and you give me a patent patient, you want a canalicular obstruction, I will mimic canalicular obstruction for you. You want a nasolacrimal duct obstruction, I will mimic that to you. It's the technique of doing which is very important. So as I was telling you, I always prefer the upper one, and then again, once you're getting into a canaliculus with whatever instrument it is, it has to be lying straight, parallel, and on the lid margin. Now, like we have cornea and retina diagrams, there are lacrimal, well-known lacrimal findings. This is how you would depict a lacrimal finding. If there's a mucocele, whether it's an enlarged punctum, punctal displacement, partial and complete blocks. So there are different diagrammatic ways of representing the lacrimal findings. For example, if you see here, this is the irrigation finding, right? This patient, it doesn't go there. So in the first picture here, I am irrigating from the lower canaliculus, and there's a complete flow into the nasal cavity. Upper, complete flow into the nasal cavity. Third picture, if you see, I am irrigating from the lower one. There is a partial regurgitation from the upper one, and there's a partial regurgitation which is demarcated by those dashed dotted lines, the partial nasolacrimal duct obstruction. On the first picture here, onto your left, irrigating from the lower, coming from the upper, complete coming. There's complete obstruction down there. Immediate regurgitation from the upper with a soft stop at the common canaliculus is depicted with the middle picture. If there is a mucocele associated with that, that's how you depict in the third picture. Right? And there are a lot of ways. If you see, look at the middle one, there is a fistula. If you look at the rightmost picture, there is a punctoplasty somebody has done inferiorly, irrigation through that punctoplasty, there's a complete flow into the nasolacrimal. So there is a good way of diagrammatically representing the lacrimal findings. Nasal examination, this is a very important concept for ophthalmologists. Remember that more than 50% of this pathway goes into the nose. And how come you do not evaluate the lacrimal drainage, the nasal cavity, if you want to evaluate the lacrimal drainage for that matter, right? Same thing for the surgeries. If you really want to take care of it, your nose has to be excellent. You just can't say that I do not know the nose if you really want to take care of the lacrimal drainage. So a simple brief anterior rhinoscopy would give a lot of clues. And learning nasal endoscopies, learning nasal endoscopic surgery, I can assure you is far easier than learning cataract surgeries. It's quite simple, there's a lot of room, right? So you evaluate the nasal examinations for the dye disappearance, for irrigation using fluorescein. It gives you a lot of clues. One of, very, very good gentleman from the last 30, 40 years back, Alan McNabb, who's still active, fortunately, has given up a very nice sequence, which I feel still holds true. So take a directed history, and then first exclude the cause of reflex tearing. Is there something on the ocular surface? Is there something on the lid margins? Is there meibomitis? Simple, right? Once that happens, then look at the punctum and make sure that the puncta is normal. If the puncta is normal, then go ahead and assess the lid laxity in one go. Palpate the lacrimal sac. Say if everything puncta is normal, there's no regurgitation on lacrimal sac, then irrigate it. Say if the irrigation is patent, then perform dye disappearance to assess the functional outflow. And if everything is okay, examine the patient's nasal cavity. Very simple sequence to that one. So I thank you for this part of the presentation. Okay, so I'll just finish the second in line. Ganga, if that is okay with you. Yeah? Can you place the second one? Yeah. So this is, following the basic, this is something that I would like to introduce you. I have introduced you to some people this particular topic. Some have already known through the publication. This is about a new disease description that we did last year, a year and a half before, which we named it as idiopathic canalicular inflammatory disease. And I know, Rick, and you won't like idiopathic again. But this is the beginning of this description. Now there is a reason why we called it idiopathic canalicular inflammatory disease. And I'll introduce this disease for you. I'm sure most of you are seeing somewhere in your clinics, and I want you to give your feedbacks and information so that we are able to better manage this thing. So what we started seeing was patients in the 4th and 5th decade presenting typically with epiphora without any kind of discharge. The lid margins, the ocular surface, everything looks beautiful. There's nothing wrong anywhere. And the only problem is that there's one punctum which is inflamed, single punctum. In 3 months' time, both the puncta of that eye gets inflamed. And within 6 months, the other eye starts showing the same features. And whatever you do, there is a relentless progression of this disease. You just can't manage it with anything. So when we evaluated these disorders, whenever you're thinking of some new description and all those things, you should describe it in totality from everything that you have at your disposal. And what careful observations can do is what this description will show you. So we found typically 5 clinical stages of this disease. The first one is a stage of progressive edema. If you see this particular punctum, right, there's so much, you can see the punctal opening, but there's so much of edema which is restricted to the punctum. Then what happens is that there is a progressive stage of progressive centripetal peripunctal vascularization. So once that edema stages disappear, it goes to the next stage, everywhere the vessels start going towards the center of that punctum from all sides. If you don't do anything at this stage, then the punctus, the mucosa starts spouting out. The difference is that it's vascularized without any discharge, because punctum pouting for us is canaliculitis, which is not true for all cases, right? So there is a vascularized area now that you see, which is elevated. Then comes the stage 4, which is a dense membrane formation, where you can see in this particular, still there's a little bit of translucency, there's a little bit of that vascularity which is still there, but it's a dense fibrovascular membrane. And then it disappears completely. I'm sure a lot of you people have seen that, right? So this is the stage of progressive scarring where everything goes off. When we do FDOCT of these stages, if you see this particular case here, this is the vertical canalicular mucosa. It starts with the vertical canalicular mucosa getting edematous. And then the edema from both the sides of the vertical mucosa is so profound that it completely closes that canaliculi. If you do a dacryoendoscopy at this stage, you find that the mucosa is white, edematous, pale, but there are areas of definite hemorrhages, focal areas of submucosal hemorrhages. if you do a histopathology of this, you would find that the epithelium is quite thickened. The canalicular epithelium is really thickened with bad inflammatory cells moving around. So when we thought, okay, fine, this looks like inflammation, so what we would do with what anybody else has done. So we started giving steroids to these people to control inflammation. It does look a little better with steroids, it never goes off. But the time you stop steroids, within a week there is 100% recurrence. So what we did was we gave steroids and we didn't want it to close or go to stage 4 or 5. So we started doing monocar dilatations and we found that this delays the progression. But whatever you do on this planet, you will not be able to prevent these puncta from going to stage 5. They will scar, at least in my experience. So the paper that I presented is a paper where I showed 100% failure in my hands. So for the youngsters in the audience, this is another message. The biggest disservice that has happened from publication point of view to our literature and medicine is that people always put up rosy findings. Rosy, 99% success, 98% success. For many things in life, the reality is not 98 or 99. We all know as surgeons, isn't it? So have the courage to put your failures because it's going to help all of us. So if you look at this particular patient, 6 weeks monocarb retrieval, look at that, still inflamed. This is in spite of the patient being on steroids and cyclosporin. Look at that. It's dilated, but still not great. Now look what is happening. This is how it happens. So once you put a monocar, you downstage it. It looks good, the punctum, right? And if you do FDOCT during downstaging of this disease, from this, it looks this. Beautiful, big, dilated one.
Dr. Javed, please, if you can.
I think there are 3 talks, and I'm going to give only 2.
So you combine the 3 talks?
Yeah, all the 3. I'm just finishing it off.
So this is the last?
Yeah, this is the last.
Okay,
yes.
okay.
So, if you look at this one, and if you, I'll just go back. Okay, so when you downstage it, it looks like this. The time you stop steroids and everything, this is how it becomes. It getting narrow, and then it completely scars, like you see the OCT there. So this is just to show you the relentless progression, even after monocars, and this completely scars down. So based on our understanding of whatever we could do, we have put up a diagnostic criteria for ICID, and we have classified it as major and minor criteria, which are necessary to diagnose ICID. You can read that. So the further work that we are trying to do, again the same thing, right? If we become mechanical and we think only as surgeons, we are not going to find a way out of this one. So we need to understand what is happening at a molecular level. So what we are doing at this point of time is we are assessing the tear fluids, and we are assessing 47 inflammatory and non-inflammatory proteins within the tears of these patients, and we are trying to see what is going wrong at a molecular mechanisms so that we can have immunosuppressive, or I don't know what kind of therapies that would come, or some bright person somewhere in the audience might come up with some good idea to take this work forward. So thank you so much for this one.